let's get cracking. Well, let's start with Dr. Grewal. Dr. Grewal, you had a wonderful talk on the role of chemotherapy, and there are times when you kind of do chemo for quick-growing cancer. Is that true for grade 1s or grade 2s also?
Hello. I think that's an excellent question. I would say in progressive disease, I tend to use it more for higher grade 2 and grade 3 neuroendocrine tumors. When I think that other therapies are not going to be helpful in getting disease control, or I worry about complications of those therapies, especially where the cancer is growing. For example, if it's growing in the peritoneum, I would try to shy away from PRRT because I worry about obstruction. So in those patients, I might use chemotherapy. In some patients with grade 1 neuroendocrine tumor, I will start with chemotherapy if I feel like their liver tumor burden is very extensive. And even though they have lower grade NET, I worry about complications in the future, and I really want to get that quick shrinkage. I might go for chemotherapy, but that wouldn't be the case with like grade 1 small bowel NETs or grade 2 small bowel NETs.
Wonderful. Dr. Starr, next question is for you. This is regarding, now we learned about Zermelo and its effect on diarrhea. Can it help with flushing? And also, on a side note, about cyproheptadine, are there any other equivalents we can use, especially over the counter for that class of drug? And I can give a quick comment on paltusotine after that.
Awesome. Yeah, I'd like for you to chime in too. So in terms of the Zermelo or the telortostat ethyl for flushing, there was some like expanded access or post-approval data, because the FDA approval is for carcinoid diarrhea. But the post-approval data did show that it appeared to decrease flushing episodes. So the answer would be yes. It may be difficult to get it approved by the insurance company if the indication is for flushing, but a lot of individuals will experience both diarrhea and flushing, and so it can kind of have a twofold effect there. But I mean, if the flushing is really severe, and I've had patients, I mean, the flushing it can be debilitating to the point where patients will describe to me, and again, you all can tell me better than I could tell you, but this exhaustion that comes over them after the flushing episodes, where they just have to sit down, and sometimes it's positional. So I've seen it be really debilitating. In terms of the cyproheptadine, it's really odd. It's a first-generation antihistamine. Sometimes it's called Periactin is the brand name. Sometimes we use it for appetite stimulation too. They use it a lot in pediatric patients, young patients, for appetite stimulation. I don't quite understand the full mechanism, other than the flushing has a histamine component. I haven't tried like Claritin or Zyrtec or Allegra to see if it had the same effect. I think the cyproheptadine is almost like a historically they've used it, and then we think that it might be specific to that drug. But I'm not sure, to be quite honest with you. Maybe Dr. Naraev or Dr. Chauhan could chime in regards to that.
Dr. Naraev?
So I just wanted to add about flushing and telortostat. So we were just talking with the telortostat company representative about it, because I believe I was the person who prescribed very first telortostat in America, because it was approved as we had patient support meeting in Arizona. Very same day we got text message, etc. So actually the trial that led to the approval of telortostat was designed to show that it's efficacious not only for diarrhea but for flushing as well. And the only reason FDA did not approve it for flushing, the results did not hit the point of statistical significance. So the results were clinically meaningful. It's just the numbers. You know, FDA is very strict how they approve certain things. They did hit the proper numbers for diarrhea, but they did not quite. But it was very, very tiny distance to the finish line. They didn't. But it does work in real life. We see it. It does work. And I agree with Dr. Starr. You cannot formally prescribe it only for flushing, but it does work when it's prescribed for any other reason.
Yes, and I agree.
As for cycloheptadine, I'm not sure. I actually never tried to use it, but it makes sense.
Yeah.
it makes sense.
Right. Yeah, if there is an underlying, histamine or other bradykinin related, maybe it'll work. Again, this is one of those gray areas. And I have a cool story about Zermelo too. When it just got FDA approved, we all get notification by FDA, and I think we arguably prescribed the first prescription. Me and Lowell were in clinic, and we literally had a patient, and we took a picture of that prescription.
We can talk about it offline.
Yes, I have proof. All right. There was a sub-question about paltusotine. This is a pill form of somatostatin receptor agonist that is currently under research. Last year, we presented data on the phase 2 study. That study tested this pill that patients take once a day for carcinoid syndrome, diarrhea, and flushing. It was an international study, and we reported out the data. The manuscript is just getting in press. So what we showed is that the drug is very effective. It's already FDA approved for growth hormone disease, acromegaly in the United States. But for carcinoid syndrome, now it has to go through the phase 3, which will be available at various centers, I'm sure, including University of Miami. So stay tuned. This is a really good alternative for patients who don't like to get poked by the injections, although injections are fantastic as well. All right, next question to Dr. Naraev. It's regarding PRRT. Is there a new beta PRRT agent that was studied recently? And can you enlighten? I think they're talking about the COMPETE study results. And how does that change? What would make you consider one drug over other, if we do have an option of 2 beta PRRT agents in near future?
Well, as always, that's a good question. There are many new drugs actually coming, because I'm not looking at the PRRT world only from neuroendocrine tumor perspective, because there are so many treatment options coming for other different cancers, much more aggressive than neuroendocrine tumors. So from practical standpoint, I think it will all depend in clinic on insurance approval. So that will be the biggest issue, because it's not just the new beta agents. There are more, for the lack of a better term, generic or quasi-generic agents are coming. So, and the much bigger issue is not the efficacy, because we know things are working based on the data. The issue will be how insurances will look at it, and how actually hospitals will look at it, and which one will end up on the formulary. Then it's not data-driven at all.
Wonderful. I agree. Okay, next question is to Dr. Rodriquez. It's a curveball. So the state of Florida, in general, has designated millions of dollars, I think maybe 80 million, you'll have to fact check me on that, towards cancer research, in part the research of fenbendazole and ivermectin. So the question is regarding, is some of that research funding go toward neuroendocrine cancer? But let me throw it a little bit wider net question to you. What is your thought on these class of agent, the anti-helminthic, and role as an anti-cancer drug? And secondly, I think this is a wonderful opportunity for the neuroendocrine cancer provider in Florida to use some of this funding and collaborate and maybe study in thoracic nets, or all nets for that matter. What are your comments?
So I think every challenge is an opportunity. I think in many ways, because we have patients that have stopped an active treatment because they saw a video of someone online who talked about ivermectin, and how, I guess, Mel Gibson talked about ivermectin. There's people talking about it. The truth of the matter is that there are people doing work on it, and it may have some kind of immune modulation effect. We haven't had a large randomized trial that has shown this to be better for any particular cancer. So there's definitely an opportunity for us to not only look at this class of drug or other drugs, other interventions, including diet and exercise, that may impact how people tolerate treatment. But I also think it kind of raises the point that misinformation kind of spreads like fire about how things can be helpful to you. And you really need to look at the sources of that information. Are they vetted informations? And when patients come to me with their bottle of ivermectin that they bought it on, you can buy it on the web. You don't even need a physician to prescribe this. Then I have a conversation about it, because I find that it always comes from people trying to get power and control over an illness that is very difficult to control, and no judgment. Like if I had a child that had a rare disease, I would be everywhere in the internet trying to find a solution. So we start from there and say, why where was the source, can we find the data? And if it's not there and you have a better option, I try to educate my patients about why don't we concentrate on what we have data for today or clinical trials that you might be eligible for. And yeah, let's advocate for use of that money where it can be more helpful.
Wonderful. Great. Let's switch gears and immunotherapy. Is there a role, or will there ever be a role for immunotherapy in grade 1 or grade 2 NETs? Dr. Grewal, do you want to take this for us?
Sure. Immunotherapy has really transformed outcomes in many cancers. And there have been some trials that have tried to look at outcomes with immunotherapy in neuroendocrine tumors. What we know is the activity is limited in well-differentiated neuroendocrine tumors. These tumors tend to be relatively cold, so they don't have a lot of immune cells in them, so immunotherapy cannot really work that well. There is some data for if you combine two different types of immunotherapies, and there are some patients, we don't know how to identify those patients, and for the most part, those patients tend to have higher grade disease, either well-differentiated grade 3 or poorly differentiated neuroendocrine carcinomas, where you can get some responses. And we know that patients who do tend to develop or have responses tend to benefit for a relatively longer period of time. It's just that we don't know who these patients are. So emerging data for sure. We probably also need to reinvent the wheel and come up with newer strategies. A shameless plug that we recently had a grant funded as a part of our collaboration with University of Iowa, where we're trying to look at combination therapy. We're combining CDK4/6 inhibitor, which is a targeted therapy. We're trying to combine it with immunotherapy to see if we can convert cold tumors into hot, and that might be a helpful strategy to sort of leverage immunotherapy and its role in neuroendocrine tumors.
Yeah, and to that point, we at University of Miami also have a clinical trial that is currently enrolling with combination immunotherapy and oncolytic virus with the same concept of trying to make these cancers more immunogenic. And Raki, who is our research manager, she's here. She can talk to you more about it. I think we might have a poster out there regarding that. Dr. Starr, next question is to you. Regarding, can runny nose be a symptom of carcinoid syndrome? And I'll also kind of club another question to this. Have you ever seen tooth decay or dry mouth as side effects of lenriodide?
Yeah, runny nose, which medically we would call rhinorrhea, I haven't seen as a manifestation of carcinoid syndrome. I'm trying to think about how that could potentially, happen.
I haven't seen it.
Yeah.
It does not mean it doesn't happen.
Right, exactly. That was yeah. So it's possible, although I haven't seen it. In regards to tooth decay, for the somatostatin analogs, lanreotide or octreotide, I was talking to someone during the break about this. So that actually makes sense. So there's a lot of somatostatin receptors in the salivary glands. And again, this is an inhibitory type of drug that sends inhibitory signals into the cell. So you'd imagine if they're attaching to salivary glands and inhibiting the secretion of digestive enzymes or saliva, if you will, that would make sense, actually. I haven't had patients describe it to me, but it's likely overlooked.
Gotcha. Thank you. Dr. Naraev, this one's for you. When neuroendocrine tumor shows progression, what are the risks of watching, waiting, or trying non-standard of care treatments? Asking when patient is trying to delay bone marrow toxicity. So, I guess these are very specific questions, but why don't we broaden it out? When is wait and watch appropriate, and what's the threshold to begin therapies, like actual anti-cancer therapies versus non-standard therapies?
Yeah. Well, the easiest answer is it depends, because as you can imagine, every patient is different, every cancer is different, every situation is different. So that's why I always tell my patients, when you read online, remember that you listen there to the experts that are experts in their own cancer, but your cancer is different. So in terms of what to do when watch and wait is okay, it depends on how how aggressive the tumor is, so the Ki-67, what the burden of the disease is. It depends, is it really progressing, is it not really progressing, and where it is progressing. So the well-known fact that among neuroendocrine cancer experts that, let's say, if cancer is progressing in the bones or in the lymph nodes, it's not nice, but it cannot kill you. You cannot die from this cancer in the lymph nodes or in the bones. What gets us in trouble is usually the liver. So if, let's say, you do the scan and there is mixed response to treatment, like everything is stable in the liver, but lymph nodes are getting bigger, that's probably okay to watch and wait, especially if it's lower grade neuroendocrine tumor with Ki-67 between 1 and 3%. Plus, as we know from experience, since neuroendocrine cancer is a living thing, like all other cancers, it has its own oddities, for the lack of a better term. For example, I personally noticed, you guys probably noticed that as well, if you don't jump and you keep watching, well, sometimes you have to jump, but if it's slow progression, sometimes things get bigger, then they get smaller. So not every progression is actually progression. So that's why, unless it's overt progression, and especially in the liver or other organs, it's probably okay to watch and wait, but it's very, very individual.
Very good. There are a few questions about grade change, grade creep, so I'm going to club them together. So the question is, what are some of the signs and how do we suspect it? Are there any diagnostic tools? And what happens when that happens? So just to kind of prime the audience, what do we mean by grade change or grade creep? As you learned earlier today, there are different grades of well-differentiated neuroendocrine tumors, grade 1, 2, and 3, based on how we see them under the microscope through Ki-67 or mitotic index and stuff. But it is now a well-established fact that a minority subset of population, over course of time under the stressors of various treatments, can evolve. And that's the nature of cancer. Any cancer evolves, but neuroendocrine tumors, they can also evolve and sometimes become more aggressive, or if it's a grade 1 becomes a grade 2, or a grade 2 becomes a grade 3. Very, very rarely I've seen few cases of grade 3 well-differentiated neuroendocrine tumor progressing to neuroendocrine carcinoma, but those are exceptionally rare situations. So that's what we call grade migration or grade creep. So the question is, how do we detect it? What makes us sense that there has been a grade migration, and what do we do about it? So Dr. Rodriquez, why don't you take this question from the lung standpoint, because we see this in atypical carcinoma all the time, between it behaving like a typical versus small cell. And then we will throw this question to our GI oncologist regarding what do we do in the GI NET space.
So many times, when we meet patients and we don't have a crystal ball, we use this kind of histologic tools to predict the future, look at big data, but in reality, in the future will need better tools to really define, what this grading difference in the microscope means for people. But in general, for lung cancer, neuroendocrines of the lung, we kind of assume that they're all gonna become aggressive. So if they're atypical carcinoids, for example, we tend to treat them like they're small cell just because we don't know which are the ones that will progress slower than not. And sometimes that makes sense because people can tolerate that, and other times that does not make sense. But in general, any tumor that we think could progress faster, we're gonna monitor more closely. And we didn't get questions about ctDNA, but that is a question that I have about, can we get better tools to really define these migrations before they really happen on real time?
Right, and just to piggyback on that comment, especially in lung world where the tumor is very heterogeneous, so there's typical carcinoma, atypical, and a high-grade carcinoma. The name atypical itself gives in because it's bizarre. It behaves sometime in a very unusual way, can be slow growing for a while, and then some of the clues that we use is the tumor growth rate. So on a scan, for several years it was slow growing, and all of a sudden it's growing like a wildfire, or there's one area that has started growing very rapidly. That is your first clue. Second clue would be you do a PET scan. If it was expressing somatostatin receptor on a dotatate PET, and all of a sudden there is an area that is not expressing somatostatin receptor, that is another clue. Then you do an FDG PET, and if that area that is, we believe, has become more aggressive or more de-differentiated, is going to be more hypermetabolic on the FDG PET, that's your third clue. So sometimes when you have these discordant biology or very confusing biology, we might need all this clues to help us. The final clue and the most definitive answer would be biopsy. So if we have the luxury to sample the area of concern that we believe is now aggressive and has grade migrated, we sample that, and that will show. The biopsy at the end of day is the gold standard way to detect what we are dealing with. So if it was atypical and now it's showing me small cell lung cancer, I have my answer. Comments about the GI world, about this grade migration?
It's not that much different, but question is when to suspect. Even closer. Okay. So it's not that much different in the GI world, but I usually tell my patients, I ask this critical question, do you watch Judge Judy show? And everybody says, no. But then I start quoting her, and everybody says, yeah, that's what she says. So what Judge Judy says, when things are not making sense, something is missing. So that's what she says. I'll leave it at that. So that's what usually happens in the clinic, right? It's usually good, old-fashioned, boring neuroendocrine clinic because it's chronic disease, right? In many cases, you do scan after scan after scan, and they all look boring, and you're happy for that. Nothing changes, right? And then there is a day when you do yet another scan, and you look at it, and things are not making sense, right? Like everything is still fine, and there's one area, as Dr. Chauhan said, one area is getting bigger. Well, makes no sense, right? So, I mean, something is missing. Then you start looking at this area because that's probably, why would it grow faster than everything else if everything else is controlled? Probably it's different disease now. And that's when you start doing these scans, the PET scans, and ultimately the biopsy. Because everything else is educated guess, and biopsy is the only one, the only test that actually gives you the correct answer when it does. Because biopsy, as you know, is only good when it shows something. Because cancers are like Swiss cheese. If you don't hit the right spot, you don't get the right answer. What do you think, Dr. Starr?
Yeah, so the grade creep or the grade migration typically will occur from grade 1 to 2, right? There's reports, two different things. If you biopsy a tumor in the small bowel and then in the liver, right, you can get two different grades. So you get a grade 1 in the small bowel and grade 2 in the liver. It's the same disease, but this is called discordance, right? So grade discordance. And then grade migration or grade creep is over time, the changes that you see, right? So also you could see this up to 30% of the time. In my mind, as Dr. Naraev said, if things don't quite fit, as Judge Judy said, then you have your answer, right? In my mind, you really don't need a biopsy to tell you what you're seeing in front of your face, right, on the scans. The biopsy would be for maybe a research, a clinical trial, right? That makes sense. But for example, I had a patient the other day, and what we were seeing in the liver, it had been grade 1, 2 for many years, and now it's growing quick. Well, we knew it was higher grade. Well, sure enough, we got a biopsy for purposes of a trial, and it was grade 3, right? So what you're seeing on the scan, it tells you what you need to know in terms of a grade increase. Do you need to define it at a granular level, 15% versus 22%? Probably not, right? You just know that something has changed. I think that's the take-home message.
I would like to add one more thing. Don't get completely stuck on the key 67. I've had patients who've had pathology review from some of the top centers and all reporting different grades. So I asked one of the pathologists, it's really like counting a herd of sheep, right? So, if there's 18 versus 16%, don't worry too much. That's each pathologist, it's in the eyes of the, like beauty's an eye of beholder. So it's not complete black and white. There's a gray area there. So what matters is the biology, how fast the tumor progressing, and then you overlay the pathology data on top of that. All right, let's keep moving. Wonderful questions, everyone. Dr. Grewal, this one's for you. What is the role of molecular tumor boards in neuroendocrine tumor management, and what markers are useful in individualizing the care, and give some comments on germline mutation testing as well while we are talking genetics.
Yeah, that's a wonderful question. I think the missing link in classifying neuroendocrine tumors has been the lack of molecular data. We've relied heavily on how these cancers look like under the microscope, and there are several limitations and challenges of solely relying on how these tumors look like under the microscope. I think when you first see a medical oncologist, at least, most of us will tell our patients, no two cancers are the same. No two patients are going to have the same journey. And yet we club all of these tumors under 3 different grades and site of origin and whatnot. That really undermines the heterogeneity of neuroendocrine cancers. I think the big molecular alterations that I'm looking for if I plan on sequencing, first of all, I like to sequence both blood, circulating tumor cells, as well as a tissue. That really gives me the full picture. That if I sequence just the blood or just the tissue, I may miss part of the picture. I tend to sequence most of the patients that come with pancreatic neuroendocrine tumor diagnosis or lung neuroendocrine tumor diagnosis. Small bowel, we know that these cancers don't carry a lot of mutations, so the sequencing is less helpful. I tend to sequence more and more of the higher grade neuroendocrine tumors and neuroendocrine carcinomas. We know that a lot of these patients will have targetable alterations, especially the ones coming from the colon and poorly differentiated or higher grade. So identifying those will open more avenues for treatments. The other mutations that I'm looking for are the more aggressive, the cancers that are more aggressive, they will have TP53, RB1 mutations, so the bad mutations. I'm also looking for those so I can sort of predict how the outcomes are going to be, and I can use more chemotherapy-based options for those patients. And I think slowly neuroendocrine tumors are making their way into these molecular tumor boards that have now become sort of like a quality metric for many cancer centers. And increasingly we are sequencing these tumors. We're putting pieces of the puzzle together on how we can leverage molecular data to open more avenues for therapeutic options, and also understand what these molecular alterations mean in terms of like the disease biology.
Right. There was a follow-up question to it. Again, it's regarding this particular patient mentioned P10, P53, and active kinase pathways mutations. Are there any clinical trials regarding that? So to my knowledge, unfortunately, these targets so far have not been druggable. TP53 is probably the most commonest mutation seen in a lot of solid cancers. So far, there are some trials, but nothing big, at least not in the neuroendocrine tumor space. However, as Dr. Grewal mentioned, higher grade, well-differentiated grade 3 is probably something that you may want to consider getting NGS testing for. I have had some handful patients who've had either high TMB and responded beautifully to immunotherapy. One patient I remember had NTRK mutation and got on NTRK inhibitor, doing great. But these are really needles in haystacks, unfortunately. So I don't want to oversell the utility of NGS in well-diff NETs, but I think there's more need for finding targets that are common in our disease type and develop drugs for them. Because the first step is in our lung world, we found the targets like ALK and EGFR, and people develop drugs for them. Now we know what are the mutations in our area, and we need smart scientists to develop drugs for them. Any comments, additional comments to supplement?
Sorry, I forgot to answer part of the question on
Germline.
germline
Yes.
alterations. I think this is an area of unmet need that has not been studied well. We actually have unpublished data showing that up to 10% patients with neuroendocrine cancers, and that includes both poorly differentiated as well as well-differentiated tumors, can have pathogenic or likely pathogenic mutations. There are two important points here. One, sometimes if your cancer has a mutation that may render, or you have inherited a mutation from your parents that would render your cancer more exquisitely sensitive to, say, platinum-based chemotherapy, et cetera, we really want to have that information. We also know that there is a drug approved for patients with germline VHL mutations. If you have a pancreatic neuroendocrine tumor, you can use belzutifan. The other important aspect of this is cascade testing. So once you find out that you have a pathogenic mutation, your first-degree relatives, which is siblings and parents if they're alive, or your children might want to get tested. So I think especially in younger people, when they get diagnosed with a neuroendocrine cancer, any type of neuroendocrine cancer, I refer them. If there is a strong family history, I refer them. But in our series, we found that there is very weak association with family history of cancer. So I think we need to study this more and consider germline testing in more patients than we have been so far.
Yeah. Just to add my 5 cents, even though in well-differentiated low-grade neuroendocrine tumors, chances are relatively low to find a mutation, let's say 1%, 3%, but in high-volume centers, even like 1%, it's a lot of people. And if you don't, if you don't look, you don't find it. So in our clinic, it's mandatory. So any patient with a new diagnosis of metastatic neuroendocrine tumor, no matter grade, no matter anything else, everybody gets next generation sequencing on the solid specimen and liquid biopsy. We always do it for everyone, because if you don't look, you will not find. And then next thing you know, it could be NTRK mutation, super rare, but extremely treatable. There are drugs. What do you do, Dr. Starr?
Yeah, so for pancreatic neuroendocrine tumors, I would advocate that patients have both what we call somatic, so tumor testing, and germline, so their own DNA. That's also included in the national guidelines for pancreatic neuroendocrine tumors. Up to 10 to 20% of patients could have some inheritable DNA mutation. Small bowel neuroendocrine tumors, the only tissue type or tumor type that I don't do it, because it's just a bland type of mutational landscape. So I haven't ever, for a small bowel neuroendocrine tumor, grade 1, 2, found an actionable mutation when I was doing it. And the literature doesn't say that you find really anything. So that's the only exception. Small bowel neuroendocrine tumor, grade 1 and 2. I don't do it, not because I don't want to offer that to the patient, but because we just don't find anything.
Yeah, this is one of those areas where we don't know yet. It's good to have a cool tool that we can do, but we are also have to be cognizant of these tools are not, cheap. They cost a lot of money, to the healthcare. So we have to justify that the benefit of doing this routinely is there consistently. All right, let's keep moving. Dr. Starr, this is for you. Is plasma 5-HIAA same as serotonin plasma levels? And I think you said you don't advocate for lug the jug anymore, right? So which one in the blood is better?
Yeah, so the data would suggest that serotonin is a little bit more fickle and labile. It can have a lot more variations, time of the day, different stress. The 5-HIAA is more of what we call a steady state. So it gives you a better representation of the overall levels as opposed to the serotonin, which kind of goes like this. The 5-HIAA can be like that, right? So I would advocate for the 5-HIAA. Again, the plasma is so much more convenient. It's it's a blood draw as opposed to a 24-hour urine collection. Some caveats to the 5-HIAA is patients who have really significant kidney issues. So the plasma 5-HIAA in patients with significant kidney issues is a problem because it's excreted in the kidneys, and if the kidneys aren't working very well, you will get a falsely elevated level. In that case, I think a 24-hour urine collection is probably the way to go, so that's the one caveat. Chromogranin, I'll mention again, it sends me and my patients in kind of circles. I don't think that it's generally helpful. It is the most commonly obtained test in patients with neuroendocrine cancers, and it's the most, it's the least helpful test. There's one situation where I do use chromogranin for patients who have advanced or disease that has spread, right? And you have a level and it's elevated, and you have a baseline, and you follow that, right? That's about the only situation in which I will use it. Otherwise, like if you're being monitored or it never was elevated, I wouldn't check it again because it could become elevated because you're on Prilosec or acid inhibitors of the stomach. So just be careful. That one will send you in circles.
Yeah, and you know, last year we published AJCC guidelines. It came out of, I think, after 5 years, so we updated it, and there's a consensus statement that chromogranin, routine use of chromogranin should be avoided because it causes a lot of stress to not only patients, even to doctors. Go ahead.
Yeah, well, since we started on chromogranin, so actually, Dr. Chauhan, we published guidelines, NETs, NETs, and COMNETs a couple of years ago, and this was the first official statement that chromogranin should not be tested. So we beat you to that.
You did.
But in general, yes, chromogranin is wrong test. We thought it would be the one to follow, and we followed, but for the last 10 years, I don't order it because it only achieves two things. Testing chromogranin, number one, it gives anxiety to the patient. Number two, it gives anxiety to the physician. That's it. That's it. Because, and nobody knows what to do about it. Because, and you have no idea, since probably you guys have the same experience. We see lots of people who come for fifth, sixth, seventh opinion. And I was surprised initially, not anymore. In how many cases and how many situations local physicians changed the whole treatment concept, the whole treatment plan, just based on the fact chromogranin went up. Like, who cares? Disease is not progressing on imaging. Because we thought chromogranin would be like good, just to think about parallels, like PSA and prostate cancer. We have good data. If it goes up, most likely cancer is progressing. The same for colon cancer. CEA, if it goes up, chances are high it is progressing. For chromogranin, in many cases, there's no correlation. There was recent attempts to justify its use. No, it's not good. And then, essentially, if chromogranin is high, what do you do next? You do CAT scan, right? If CAT scan shows stable findings, what do you do next? Relax. So what was the point of doing chromogranin if you do CAT scans every 3 to 6 months anyway? So no, I wish it was showing something. I wish we had it, but no. I know Dr. Chauhan is working on other new generation tumor markers that might be more reliable.
We got you guys. We have a new thing cooking, but wait up.
Yes. So this is chromogranin. So in general, should not be tested ever, period.
Right.
So I know it's a strong statement, but still, I stand by it. For the last 10 years, never ordered.
Yeah.
So 5-HIA, there is one more scenario when we would do 5-HIA, and actually kudos to the company who designed this test on the plasma. So sometimes people cannot afford it. Co-pays are high, or let's say out of big companies, so LabCorp has it and Quest has it. Let's say Tampa General does not have it in-house. We have to send the patient. If, let's say, LabCorp is not signed with insurance or Quest is not signed with insurance, you don't want to see that bill. So this is your plasma testing. Well, the jar is essentially collecting 24-hour urine for 5-HIA. That was a good old-fashioned test. It creates lots of memories. So it's not just apple juice confusion, but I'm usually perplexed how people drive across the town to deliver the jar of the gallon of urine, and you're driving with that. It creates memories. It's still good and reliable test, not to be discounted. So we always try to do plasma, but sometimes it's not feasible.
Right. Great question. We keep moving forward. Dr. Rodriquez, this one's for you. This is a very common question, I guess, across different cancer types regarding role of supplements. And which one are recommended, which one to avoid, like curcumin, vitamin D. I mean, I can go down the list of the rabbit hole, right? So what are your general thoughts about role of these supplements and its role, and are they safe to take?
So I think it's safe to bring the whole list of things you're thinking of taking and bring the bottles to us. We're lucky enough that we have a pharmacist that helps us sometimes. Just because it looks like it's natural doesn't mean that it doesn't interact with some of the enzymes in your liver that are processing your treatment. And you'll be surprised that some of the supplements sometimes make the chemo drug that works not work as well. So you have to bring them to us. We have some common kind of recommendations that if you're getting radiation, we like to stay away from antioxidants during that period. We don't believe in, at least I don't believe in high doses of vitamin C. I think that the data for high dose vitamin C, I always tell patients, for me to give you the dose of vitamin C that will kill a cancer in an experiment, I will kill you with that dose of vitamin C. So sometimes those things don't, there is data for something they did in the lab, but it's not applicable to the things you're taking by mouth. And people spend a lot of money on that. So I think it's important not to have shame that you found this, like your doctor should sit with you and see, like I go through them and okay, this one's, we looked at the ingredients, they look good. This one's, we don't know what the ingredients are. We don't even know where it comes from. So we're gonna stay away from that one. But I think in general, and we're gonna have a talk on diet and nutrition, I think patients who are interested in supplements, they're also very interested in diet modification, and we do have a lot of diet information about diet and exercise changing the course of chronic diseases. So we don't want you to stop thinking that way. Yeah.
Right, I agree. I think, I draw the line at coffee enemas, but after that, before that, as long as it doesn't interact, and the pharmacists are very good resource.
Well,
Dr.
you didn't
Naraev.
practice in Arizona. So coffee enemas is not, hot chocolate enemas is the thing.
Oh, okay.
Yeah, that was the thing in Arizona. Yeah, but the truth about supplements is that we just don't know. We just don't know. Maybe they're good. Maybe they're not. We do not know. Why we know what we know about our drugs?
Right.
Clinical trials, right? So we can prove. For supplements, maybe they're good. We don't know. But this is the whole problem. And the biggest concern in the clinic, we are not worried about the supplements not treating cancer or treating cancer too fast. Problem is, what if they will make our treatments, chemotherapy, inactive while still keeping side effects? And again, we don't know, we're just afraid of it. So, but there is Memorial Sloan Kettering, MSK, they have special website. So when people can go, patients can go and put any supplement, and it will give you all the information you might want to know about the supplement. So the truth is, we just don't know. It's lack of information. So clinical trials are needed. Problem is who would sponsor them.
Right. Yeah. But sometimes because of the lack of data doesn't also mean that there is a supportive data. I remember a patient of mine invested $30,000 in a what's called hyperbaric chamber. So, there's a lot of information out there which hasn't been proven, and do it if you can. If that's couch money for you, it doesn't matter. But please don't be misled by a lot of misinformation out there in the internet.
Yeah. Could I add two more things? So since we're on the topic
We
of
have
supplements.
okay,
Yeah.
just one thing. All right.
No, just when people talk natural treatments, that exist in nature, think about the fact that many chemotherapy treatments, if you look by that standard, they are natural. Platinum-based drug. It's platinum in the same that we use for jewelry, right? Many chemo drugs come from plants. They're as natural as it gets. They're poisons, but they're as natural as it gets. So the chemotherapy is not that far away from everything else that comes from nature. And speaking of nature, it's my second point, but I'll put into the one. Who heard about turkey tail mushroom? Yes. Oh, you too. So, and
What kind of mushroom? Okay.
Turkey tail.
Oh,
Turkey tail, not that kind of mushroom. So turkey tail mushroom. So what I know is I had to dig deeper into that. The people who sell it, they tell patients, oh, there was a clinical trial. Okay, so I looked into that. There was a clinical trial. There was phase 1. It's still listed. When you Google on clinicaltrials.gov, turkey tail mushroom, it's there. It was there. There is no results, no publications. Nothing came out of it. So, but you need to know that. But when people tell, oh yeah, this turkey, take it, there was a clinical trial, means nothing unless it's published result.
Agreed, 100%. All right, this is $1 million question. I don't know if you can sort it out today, but I'll ask. If my tumors have grown, how do I choose between everolimus, cabozantinib, Captem, Lutathera, or clinical trial with alpha PRT? Quick comments, like literally 10 seconds each panelist. Go for it.
I would say there's no short answer to this question. It's a very nuanced question. But few things that we're looking for is how quickly the cancer is growing. Does your cancer still express somatostatin receptors? Have you received PRRT in the past, and are you still a candidate? Is surgery an option and would be a better option? So you could be a candidate for multiple therapies at the same time, but we have to choose between those based on all these factors. And it's also important to consider, do you have any other health conditions that these therapies may make worse, so they fall further down on the list? And if you have carcinoid syndrome or other symptoms from your cancer, are these medications going to potentially make them worse, which would put them further down on the list?
Can I modify it a little bit for other panelists? So that was a great answer. What if, because there's another question, what if it's just a bone-only metastatic disease, there's nothing in the liver?
That's a completely different question.
Yes.
Okay, well, short answer to the first question, how do I choose? Short answer consists of two parts. A, talk to your oncologist and listen. B, and after that, go and ask for second opinion. So, because one size does not fit all. So, and it's very complex decision making. It's very complex decision making. But second opinions are good. Third opinions are good, up to seventh. Past seven opinion, probably if everybody tells the same thing, that's probably what it is. So as for bone, if it's only progression in the bones, so it depends how bad it is. If the bone involvement is present, I would probably be thinking less about PRRT because of risk of bone marrow damage. But again, you cannot die from this cancer in the bones. You cannot.
I would add to that goals of care, ask your oncologist, but come in thinking about what's important to you. So all of these options that you have different side effects, from being in the bathroom a lot to like having to get an investment in going to the hospital to get an infusion that requires radiation and imaging that is very difficult to set up. So all of these things involve a lot from patients, and I find that patients need to tell us what's important to them. Like, do you have a holiday coming up, or do you really need to do this trip and you want to be in an oral drug that has less checkups and a drug that has diarrhea? So I think, you're part of the conversation and you're part of the decision making. And I agree, second opinions can open the door for things that your local doctor wouldn't have thought of.
Great. I'll twist the question a little bit now. With PRRT, alpha or beta, which one is the winner here?
Yeah, I think right now, definitely beta. We have almost 8 years of safety data, at least in the US, and more in Europe. So I think that's a slam dunk that lutetium-177 dotatate is the way to go. Now, the alpha particle therapies are offering the promise of better response rates, better disease control, improved outcomes, but that has not been fully realized. And we don't have long-term data on safety for alpha particle. Maybe it has a higher risk of leukemia. There's more fatigue, there's more diarrhea, there's more hair loss. So what is the trade-off in terms of a more powerful agent in terms of the benefit, right? We talked about that balancing of efficacy, quality of life, or side effects. So I think that we might be getting a little ahead of ourselves with the alpha particle in terms of saying like, oh, this is going to be better and this is the best, when we just don't know yet. Now, there was a trial that just completed accrual. It's through RayzeBio or Bristol Myers Squibb, actinium-225. These are patients who had gotten Lutathera already, and then they had progressed after Lutathera after a period of time, and then got the alpha particle therapy. So we'll see after Lutathera if the alpha particle, is the way to go. There'll still be some caveats there. But as far as frontline, as far as like the first RLT, PRRT that you should consider, it's the beta particle, slam dunk.
Dr. Naraev, to build on that conversation, a lot of questions on PRRT. Is it okay to take a little longer break after a third round to recover for the counts, and how long is it safe to take the break from PRRT?
Well, short answer, yes. It's like with any other treatment, if counts did not recover or you don't feel good, it's okay to wait. So it's perfectly fine. We do it for any other treatment. It's perfectly fine to do it for PRRT. So what was the second part, sorry?
No, I think you answered it. There's really no magic to that every 2-month interval. That's how the study was designed. And the new study we talked about is every 3 months, the ITM compete. Yeah. So you need to take as much time as your body needs. And there are patients which only get 2 doses of PRRT because the counts don't recover. So we don't want to push you beyond your capacity to recover.
Yeah. It just tells you, yet again, how much we do not know. So all those schemas and regimens, they're very much arbitrary. When you start asking, like, and why is it like that? Or that's how the trial was designed. Okay, you dig deeper. Now, why the trial was designed this way? Why did you decide to do every 8 weeks, not every 6 weeks? Or it was the expert opinion. This expert opinion we got together and said, well, let's just choose something. And that's how it was. It's not like, oh my God, there is a secret that we are not sharing. No, so it's perfectly fine to wait. If the body is not ready, the body is not ready.
Dr. Rodriguez, this is an overarching question which is troubling a lot of us and our patients throughout the U.S. What's the current status of Zoom calls or televisits in the U.S.? Can you enlighten us a little bit?
It's the same status of your airplane controllers. So actually, there's some hope, So advocates, and before the government shutdown, if you don't know, the telemedicine rule that was started during COVID and allowed us to really improve access, because patients don't have to take a day off to come see us, like they're really interacting with us by telemedicine. That was changed to then it only includes in-state conversations, so you cannot do telemedicine with someone in a different state, but at least in the state, it's very helpful. So right now, it's in limbo, and every institution is doing different things. So our institution is allowing patients to schedule these visits with a lower fee or like an out-of-pocket fee potentially, because sometimes we're hoping that these things will be retroactive. But the advocates have to be out there saying that this, to their, call your legislator and say, this matters to me. Like every time I have to go to see a doctor, like my kid has to take me, someone has to take me, we lose money, we have to get on traffic, it's not safe, we're sitting there with other patients who are on chemo. So telemedicine has really revolutionized what I do, and what we all experience is a better experience for many of our patients. So I think it's gonna come back, but I think we all have to be out there saying that it's really critical for patient care and access.
This is probably the only good thing that came out of COVID era, the telehealth, right? Let's keep it. All right, let's move on. Dr. Grewal, this is a loaded question for you. Is there a possible cure in our lifetime for neuroendocrine cancer? And a follow-up question, anything in your eyesight that you came across that is cutting edge, bleeding edge at Europe and might come to US soon?
I think the hope is that we will be able to cure, and I think those of us who take care of patients with neuroendocrine cancers and work as investigators, I think we're going to be the last ones to give up hope. So the hope is alive. And with that said, I think cure also means different things to different people. So I think for some people it may mean that I'm able to live my life for as long as possible with great quality of life, and that's something we strive for always. And for some people it may be that their cancer scans are NED or no evidence of disease, and our hope is that one day we will be able to achieve that. The second question, I think in the last couple decades at least, what we are seeing in our field is this effort to globalize everything, and partnership between the US and European nations and beyond. So a lot of our clinical trials are global. So it's not the same anymore as it was like maybe 10 years ago, where patients had to go to Europe to get PRRT, like Germany, Switzerland, Australia, et cetera. So a lot of the ongoing newer novel therapies, I think, are global studies, and a lot of them are actually being conducted in the US. So I think I'm really excited about alpha PRRT, although Dr. Starr rightly pointed out that we have to be exercising cautious optimism here. I'm also very excited about novel cellular therapies that will help our patients with high-grade neuroendocrine neoplasms. I'm also excited about CAR T-cell therapy coming to small bowel neuroendocrine tumors. We have that trial open at Emory. So a lot of exciting progress, and the good thing is that there are global studies, so our patients don't have to go to Europe and other countries for clinical trials. They're very much available here, and once they are approved, they will be available in the US as well.
Can I just add to that?
Yes.
Hope is definitely alive, and just to tell you, the investment we make in research, our advocates are out there doing fundraising matters. So I will give you one quick example. Small cell lung cancer had the same treatment for 25 years, and it will stop working at 1 year. They just presented in Europe, adding tarlatamab, which is a new bispecific antibody, the first one approved in solid tumors, approved for this rare lung cancer that 80% of people are alive at 1 year. So really, the hope is there and real, because the science is moving faster than it ever did. Small cell had nothing for 20 years. I mean, I'm sure these drugs could have been developed earlier if there was if the science had moved faster. To move the science faster, we have to participate in trials, we have to raise money so that we understand how these new drugs can be applicable for neuroendocrine tumors too.
And to Dr. Rodriguez's point, the tarlatamab drug has been an absolute game changer in small cell lung cancer, which are a high-grade neuroendocrine carcinoma, and we now have access to these trials. In fact, our site is one of the top accruers in the US for the Darien group of studies, Darien 5, 7, and 9. And that goes on to show that Europe no longer has the monopoly in the most cutting-edge stuff. In fact, I would argue we probably have more innovative trials in the United States in the current era. And let me go even a step further. I think China is eating our lunch. The kind of innovative stuff happening in China is mind-boggling. So it is good. Any innovation anywhere in the world, it's a win for scientific community, it's a win for the patient. Let's all work together, find a cure together.
Well, speaking of cure, let me look at a different angle. Remember we talked about it earlier about neuroendocrine tumors, especially low grade, being sort of chronic disease, right? Because it stays forever, we have more treatments, we can control disease longer. Think about other chronic diseases. Do we talk a lot about finding cure for hypertension? No. We talk about finding new drugs to control it. What about diabetes? We cannot cure it, but we know how to live with that, right? We're coming up with the new drugs. Well, what else could you think? COPD, right? The chronic lung disease. We're not looking for cure. I mean, we're probably looking, but we're not like sitting thinking, oh my God, the cure should be that. It's chronic disease, we just learn to live with that. And I think that this is sometimes good approach for lower grade neuroendocrine tumors. It is a chronic disease. We hope to find cure. The research is ongoing, but even if we don't find it, look how many more treatment options already there. So I still remember the day when everolimus was approved for neuroendocrine tumors, there was nothing else. Nothing else. So look right now, it's not the issue how to treat the patient, with what? The issue is how to sequence. That's usually the theme of all the meetings on neuroendocrine cancer with experts, the sequencing, right? Like not too many, way many treatments we don't know how to sequence. So if you look at it as chronic disease, it gives you even more hope than just, oh, the people are working on cure. That's great. It probably will happen in our lifetime, but the chronic disease is being better controlled now. The chronic disease that neuroendocrine tumors are.
Great. I think those were great words to conclude our session.